Well, good morning, everybody, and welcome to the first of today's webinars from Smart Vision Europe. And we're starting off this morning looking at various applications for using SPSS in healthcare settings. My name is Jarlath Quinn. I'm an analytics consultant at Smart Vision Europe. I'm joined online today by my colleague Rachel, who'll be making sure that everybody's logged in correctly. If you haven't joined any of these sessions before, I know that some of you have, but if you haven't, then you should be aware that the sessions are recorded. So you'll be able to listen to the recording afterwards. We also have a series of recordings that we've made from previous sessions, which are available on our website and also available on YouTube. And there is some slideware here. So we'll email a copy of the slides out to you after the session's ended, or you can get a link to download them. As you think it's particularly relevant for colleagues who are unable to join today, and you can get enough of them together, you could just drop us an email or something like that, and we'll see if we can arrange it to rerun it on a private basis. And with regard to asking questions, well, all the lines are muted, so we can't hear you. But we ask you use the chat panel. We try to keep an eye on them on it as we're going along. If we do run out of time or if we don't get a chance to answer your question, then we'll try and follow up with you offline. But by all means, do send an email to us afterwards if anything occurs to you with any follow-up questions, and we can all try and answer them as thoroughly as we can. If you don't know who Smart Vision are, we are a gold accreditor partner to IBM. So we're a technology company, and we specialize in statistics, data mining, all that kind of stuff, machine learning, AI, data science. And we also work with open source technologies like R and Python and Spark. We're a relatively small organization, but we have a very deep experience. So all the people in the team have about 15 to 30, 35 years of experience working in statistical software and data science and machine learning and all that sort of stuff. And that means we've got a lot of experience applying these types of technologies and these types of applications across a very wide range of sectors, including, of course, public sector and healthcare related sectors. But not just excluded, not just exclusively for those. In fact, we find that you can, if you know a lot about how different applications, different sectors, you can take one and apply it to another one, and that's certainly something that we've done over the years, where we've taken applications from one sector and found that it works quite well in a completely different application. Our agenda today is to try to take a little walk through a bunch of different techniques which are typically used in healthcare settings. Some of them are fairly basic, some of them are a bit more complex, but we wanted to try to cover a bunch of things which, we think that s- people are likely to find useful almost in whatever context they're working in, whether it be administration context or whether it be a research context. So we start off today talking about just something very simple, very gentle, looking at working with patient satisfaction data. Everybody has satisfaction data, of course, that most healthcare facilities have sort of patient satisfaction data, and knowing a few good ways to analyze that can be very useful. That actually does bleed into correlations. We'll be looking at interpreting correlations. The two things aren't mutually exclusive. You can use one against the next. And then we'll look at using a technique known as decision trees before we just touch on odds ratios and relative risk scores, simply because these are used so often, they're so commonly associated with healthcare statistics, and we thought it'd be useful for people to see how do you work with those within an SPSS context before lastly exploring something which is very, very strongly associated with a healthcare analysis, which is a survival analysis, and we're going to be looking at Kaplan-Meier survival analysis. So let's take a look. Let's start off talking about working with satisfaction data, and we're going to be looking at a few techniques and approaches that we can deal with that. So this is a data set I got off the internet. It's patient satisfaction or some sort of clinic satisfaction data, and it's very typical of the sorts of satisfaction questionnaire type data that you get. How many records have we got here? We've got 452 patients that have been asked about their level of satisfaction about a range of different things. So first of all, we've got overall satisfaction here. If I just right click on that within SPSS and hit descriptive statistics, you see it gives me a little table here saying that, 25% people are very dissatisfied compared to 16% people who are very, very satisfied. And there's some variation here. So about 47% of people fall into the dissatisfied group, and the remaining group fall into either neutral or satisfied or very satisfied. And we're interested in how these factors relate to one another, of course. One of the only demographic variable that we've got here is age band. And the rest of the field, if you look at the name, what they're about, they're actually asking people about their level of satisfaction of checkup appointment, waiting times, admin procedures, hygiene and cleaning, time of appointment, quality of experience with doctor, specialists available, exact diagnosis, modernness of equipment. Measured. What you generally tend to find with these types of uh, questionnaires and this type of data is that you find that if people are satisfied with one thing, they tend to be satisfied with other things. So they tend to correlate, You don't tend to get situations where people who are very dissatisfied with admin procedures, for example, or very satisfied with, hygiene and cleaning. You don't tend to get that. You tend to find that there's some sort of level of correlation between them. And one of the simplest things you can do is simply do a cross tab. And here I'm going to look at particularly overall satisfaction against age group. So I'm just going to look at that and we'll do a cross tab first of all to do that. So, excuse me, let's just go to analyze descriptive statistics and down to cross tabs. Um, and if I just choose a field here, choose a variable here, what I'm going to do is I'm going to choose overall satisfaction. I'm going to choose age. It doesn't really matter which one goes where here, but I'm happen to be putting the age group into the rows of the crosstab. It really doesn't matter. It's what's more important is the direction of any percentages you add in. I'll put overall satisfaction in the columns. Now, if I click OK at that point, um, I'll just generate a really basic table at that stage. So here's a real basic table. And you can see that, yeah, it's telling me the count of people in, each of these groups, 30 or younger, 46 to 59, against the number of them who were very dissatisfied, neutral, satisfied, very satisfied. And of course, that's um that's fine, but it's quite hard to interpret because of course the group sizes are different. You can see we've only got 89 people who are 30 or younger, but we've got 106 people who are 60 and older. And as a result of that, we tend to add in percentages. So if I call up the crosstabs again here and go to sales, if I add in row percentages, then I'll be taking the percentage of each age group since age group is in the rows. If I click OK at that point, I'll get a slightly more complex table here because I'm adding in percentages as well. I can just highlight, make it a bit bigger, make that column a bit wider. And you can see here right away, we're looking at just look at the extremes, very satisfied versus very dissatisfied. 25.8% of the 30 or younger age group are very satisfied, compared to 18.1% of the 31 to 45, compared to 13% of the 46 to 59, compared to 60 and older, only 11%. And conversely, the people who are most dissatisfied tend to be the older age groups, with the younger age groups tend to be less likely to be dissatisfied. So it does look like the older you are, the more dissatisfied you are, and the younger you are, the more satisfied you are, which is interesting. And at this stage, we don't really know whether or not these differences that we're observing are simply, are simply artifacts of random variability, or whether or not we would use what we use the term statistically significant. And statistical significance is when we add in a test. something like a chi-square test, which would be appropriate for crosstabs. And to add that in, I'd go to statistics here and click chi-square. And the chi-square test tests the null hypothesis, or tests the idea that the two variables are independent of one another, that the age group is in no way related to overall satisfaction and vice versa. Doesn't mean that one's dependent on the other or anything like that. Okay, if I click OK at that point, you can see that we get what's called a Pearson chi-square. This is a classic chi-square and a likelihood ratio value, which is a kind of more modern version of a Pearson chi-square, better when you're dealing with smaller sample sizes. Either one you could quote here, but what's important is that, most people would say this is statistically significant, but it's just under the threshold of what we'd call statistical significant. It's just under that threshold. The threshold is normally 0.05, meaning 5%. Meaning it has to be a 5% chance that observing a result as extreme as the one you observed could occur randomly. And we would reject, in this case, the null hypothesis that age group is unrelated to overall satisfaction, or that they're independent of one another. If you double click on these pieces of output here and right click and go, what's this? You can see it says significance level based on the asymptotic, that means estimated roughly, estimated distribution of a test statistic. Typically, a value of less than 0.05 is considered significant. And you can see here, our value here is just under 0.05 at 0.041. So it is statistically significant, but it's just barely so. Now we could add in other variables here. We could say, okay, let's say if we could split this by gender or something like that if we had that. Or I could say is overall satisfaction independent of something like exact diagnosis. Now, in fact, in every single variable here, it is related to overall satisfaction, and they all return Pearson chi-square values. You can see that these ones aren't close to 0.05 at all. They're really tiny. It doesn't zero here doesn't mean it's zero. It actually means it's infinitesimally small. It's 121 decimal places back. So there's a lot of zeros in there before you see a number. So it means it's highly unlikely that you would get a result like this randomly, and therefore you'd be rejecting the null hypothesis that exact diagnosis did not in any way be related to overall satisfaction. Well, we'd expect that kind of, expect something as important as diagnosis would be related to your overall satisfaction of a medical facility. But let's say we wanted to illustrate this in some way. Well, you can go to crosstabs here and you can ask for what are called clustered bar charts. You can do that and they'll give you a little clustered bar chart. Most people find that a wee bit tricky to make sense of. Some people are better than others, but and you could edit this. You could edit this and change it. What I would normally do though is I would for this type of data, I would go to graphs and go to chart builder. And I would ask instead for a stacked bar chart. So I'm going to ask for a stacked bar chart that looks like this. I'd put overall satisfaction into the colors, which is the legend box, stack colors, and I'd put age group along the bottom. And then there's different ways in which I can do this. I can click this like this and then edit this. So I can edit that and say, okay, look, just change that to 100%. So now it's scaled to 100%. Or alternatively, I could do it inside the dialog box back here. I could go to options. No, sorry, I could go to bar here and change the count to percentage. Change that to percentage over total for each X category, and that will do the same thing. So I could do it before I run it. And with regard to the chart appearance, well, the colors are a bit odd. You can change the colors here. You have got other colors that you can apply. Look, you can do that's American Psychological Society. You can do legacy colors. I've actually have my own set of templates that I use. So I would just go to user set specified here, and we allow people to download these from our website if they want to use themselves. And I would use for something like a rating scale type question like that. I would use something a template I call Lollipop here, Click OK and click all right. And now you can see that this is really what's happening. You can see that look, here's 60 and older. Look at the proportion who are very dissatisfied compared to the proportion who are very satisfied. It's just much more visual to represent it that way. And we can see that these proportions are getting the satisfied groups kind of not they're not that different. It's really the extremes which seem to be affected by age group. But if you don't like the way it's representing this, you can actually copy it. And if you just hit actually you just hit copy, right click and hit copy, it will copy it as a Microsoft graphics object. And if you go out into say a blank Microsoft application like PowerPoint or Excel or Word or anything like that, and then right click and just hit paste, you'll find it will paste it looks different. It pastes it as a Microsoft graphics object because it actually pastes the data in the background. And here it hasn't scaled to 100%. But if you go to if you change this to click on one of these and just say, okay, look, I just want to go to chart design here. Or you can change the chart layout. So you can say, okay, I want it like that, or you can go to change chart type and say I want it as a actually want it as a scaled scatter plot, and you can go to change colors, of course. You can change the colors as you so wish, and you can change the layout. You can put them like that, or show the relationships between them and add in colors. So there's a lot you can do here if you just want. You can use SPSS to do the kind of heavy lifting to produce the charts, but you could use something like Excel or PowerPoint, something like that, to then paste the data behind those charts and change the chart type and modify and edit it to your heart's content within that application. So a good little trick to know about when you're working with what we call ordinal data. Ordinal data means rating scale data, which you're going to get a lot with sort of patient satisfaction data. That's one way in which we can work with patient satisfaction data. Another way is to look at the relationships and the strength of the relationships between the variables themselves. And that introduces us to the concept of correlations. So, correlations are values which measure the strength of association or relationship between pairs of variables. And a correlation is a number that runs from -1 to +1, basically. This goes from -1 to +1 with zero in the middle. And the closer it is to these extremes, the more perfect the relationship is. So, of course, most correlations are somewhere between these extremes. If you had absolutely no relationship between the variables or the factors, you just get a correlation of zero or very, very close to zero. And Pearson's R correlations, if we were looking at something like continuous data here, which is scale data, which is number data, basically, we're looking at numbers rather than rating scales. You can kind of look at a scatter plot and guess what the correlation is. Just if you get fairly experienced at it, you can guess what the correlations are. But here we've got a really strong relationship here between vehicle weight and horsepower, for example. So each of these little dots here is a car. This could be like, weight and height or something like that, because we know BMI, weight and height tend to be related to one another. Um, and here it's giving us quite a strong correlation of 0.859. So that's quite, if you look back here, kind of up here. It's quite strong. It's not perfect, but it's very strong correlation. You can see it's trying to form a line. This next one is weaker. This is miles per gallon against time to accelerate from 0 to 60, 0.434. So it's a lot weaker, but still a positive correlation. So it's kind of forming a diagonal line here in a rough cloud. The next one is a negative correlation. This is like a negative correlation. This is horsepower against time to accelerate. So this would be like um it would be something that had like alcohol intake and reflex reaction time or something like that. So more alcohol, the poorer your reflexes, So it could be something like that. Or pain medication against a pain score. So you'd expect a negative relationship here. So this is strong negative relationship. And you can get situations where you have very, very weak correlations that are very close to zero. If I jump out back to SPSS here and go to the correlations button up here and go to or run some correlations up here, I can do so by going to Analyze, and then down to correlate or looking at correlate the correlation sub-menu here. There's lots of different types of correlations here, but the one we normally go for is just bivariate. Click on bivariate. That means pairs of variables. I'll just pick one to begin with. Let's look at, for example, patient age group against overall satisfaction. We'll just start with that. If we go for that and say uh, patient age group against overall satisfaction, show us the what's called the Pearson's correlation here. We know it's going to be between -1 and +1. We kind of expect it to be, is it negatively related? I can't remember if it's negative correlation or positive correlation, but we'll have a look at it. I click OK at that point. It's actually a negative correlation, means the older they are, the less satisfied they are. So but it's very weak. As you can see, it's actually minus 0.166. So this is the difference between doing a significance test, which says that the two factors are related to each other, or that they're not independent of one another, and one which actually measures how strongly related they are to this. So we remember that in the significance test, it was just below zero point zero 0.05. And as a result of that, this is quite a weak relationship. So it's a negative relationship. And to show why that is, if we look at the coding here, we can see that, you know, very dissatisfied is coded as 1, very satisfied is coded as 5. And patient age group, as you'd expect, the youngest ones are coded as 1 and the oldest group's coded as 4. So as you get closer to 4, the closer you are to 1 on this scale. And as you get closer to 1 in this scale, the closer you are to like 5, which is very satisfied on this scale. So hence a negative relationship. But let's say I did something like exact diagnosis against overall satisfaction. What's that? What's that relationship like? Well, here it's showing a score of 0.661, which you can see is now it's been highlighted here. This is called a curated help. Basically means it color codes. It says this is a positive correlation of overall satisfaction against exact diagnosis. The other numbers in here are simply the number of cases. And the significance value is simply telling you whether or not that correlation is likely to be zero. And we're rejecting the null hypothesis that it's probably zero, meaning that there's no relationship. So it's not hard to get, a strong, a low probability value and to reject the null hypothesis, even with a weak correlation, because you're not testing whether it's a strong correlation, just testing whether or not there's a correlation there at all. You should be aware that we actually do a webinar just on correlation. So if you're interested in this, you can go into more detail. And you also notice that this is repeated each time. So overall satisfaction against itself is 1. Of course it is. Perfect correlation. Exact diagnosis against itself is 1. An exact diagnosis against overall correlation and overall satisfaction, and overall satisfaction against exact diagnosis is just repeated. So it's like a mirror image. And as a result of that, when I click on bivariate correlations, I can say, show only the lower triangle and don't show the diagonal. And then it just shows me the single correlation of exact diagnosis against overall satisfaction. So that's useful. And if I can add in the other variables now. I'll add them a few extra ones here. So I can add in age group. I'll add in, let's see, waiting time. Let's see, quality of experience with doctor, friendly healthcare workers, waiting rooms, and availability of drugs. We'll put all of those in. Click OK. And now we get a big matrix of correlations, you see, and it's showing us where the negative correlations are, where the positive correlations are. In fact, you can double click on these tables and you can call it what are called pivot trays, which means that you can hide the statistics. You can put the statistics and layer them on top of one another. The statistics here are, in fact, the significance test, the number of cases, and the Pearson correlation coefficient. So look, if I show these are all the ones which aren't statistically significant, are the stuff related to age group. Look, that's no real correlation here. This is not statistically significant. The rest are, but let's see how weak that is. That's with Pearson correlation. Well, it's very close to 0.049. So, it's quite close to zero. And then the end's just the number of cases that were used in the calculation of it. So this is a way for us to see where the strongest relationships are. And again, that's quite useful for working with data which is related to satisfaction. Before I stop doing this, I should point out Again, if you check our recorded webinar on this, this correlation method we're using here is called Pearson, and it kind of assumes the variables are going to be linear. They're going to be scale variables, number variables. These are rating scales, so they're not real numbers. And for that one, you might use something like Spearman's correlation. It sounds like it's kind of a anagram of Pearson's, but it is. But it is a different type of correlation. It tends to be slightly weaker, but it's more appropriate for rating scales. So if you are working with rating scales and you want to quote correlations, then maybe Spearman's would be a more appropriate one to work with. Okay, that leads us to our next section. So our next section now is going to be looking at what are called decision trees. And again, this slightly more complex this time. So decision trees are used to build profiles of patients or staff or research subjects. They also find key behavioral segments and they allow you to generate predictive models all at the same time. And they're very popular because they're very visual representations of models and they're relatively easy to understand. So, I mean, one of the examples that's used a lot is something like survival on the Titanic. When you look at the decision tree, this is what the top of a decision tree looks like. It's a very visual output. It starts off showing you all the data that's been added into the analysis. In this case, as we can see, it's the number of passengers on the Titanic, which are 2,200, of which 32% survived. And these are our baseline proportions. And what the decision tree does is it runs a chi-square test in this case, and it splits the data by by the variable that has the lowest or the smallest probability value, since it's probably the best discriminator, which in this case happens to be the gender, the sex of the passenger. So it's really good at building a hierarchy of the factors which impact an outcome. So here we have, for example, male and female. We can see that men 21% survived compared to females 73% survived. And we can also see that there were 1,731 men and only 470 females. So when we ask the decision tree to build itself and to go further and say, well, what other variables split within these groups because it's creating these segments or groups. We can see that in the gender branch here that it's actually splitting them by male, female, of course, and then for men it's splitting them by whether or not they're adult or children. You know, it's saying, look, if you're an adult male, 20% survived. If you're a child male, 45% survived. It's very good at pointing out exceptions to rules. So, for example, here, I think most people would assume that the people with the least likely chance of survival would have been adult males traveling in third class, whereas survival rate is 16%. But in fact, the lowest survival rate was adult males traveling in second class, 8.3%. For females, it doesn't include the variable age. And the reason it doesn't include the variable age in the female branch is because it's not statistically significant. It doesn't make a difference to your survival, which again is very interesting in and of itself. And secondly, we can see that instead of creating four groups for the class that they're traveling in, it's actually grouped together for females, second class, and crew. And that's because their survival rates are so similar to one another that you might as well just group them together. So it does that automatically for you. It says 87% of female crew members and traveling in second class survived. So you can imagine how this would be really useful if you're looking at something like satisfaction, what are the primary drivers of satisfaction? But it's also, very useful if you're looking at things like, how people recover from uh, from operations and whether or not individuals are likely to be readmitted to hospital within 30 days and so forth and so forth. Anything where you've got a key outcome and you want to know which factors impact that outcome, a decision tree is a very powerful way to investigate that. So In that case, I'm going to go back here and going to say, let's go to analyze. I'm going to go down to classify here because this is actually a classification technique, it's called. And we go to tree. And I'm going to put overall satisfaction. That's going to be my dependent variable. Actually, before I do that, the problem with overall satisfaction is there's quite a few categories in there. If I show you a quick example here of decision tree, it's kind of hard to interpret because there's five groups in there. So I just picked up these guys here and did that. You can see that look, there's a lot of groups in there. So I'll just run a quick piece of syntax which will code it down to three groups. So it'll just group together the very satisfied and the satisfied, and the very dissatisfied and the dissatisfied. If I run that, it creates another variable for me, and then go to the decision tree here, swap that out, and look at overall satisfaction three group, and then I pick up the rest of the variables in here. I'm going to chuck them in. At the moment, it's just going to build a really basic decision tree for me. I'll show you how you can get it to build a more complex one. It's using a method called CHAID, which is based on chi-square statistic. We click OK at that point. This is what we get. We double click on it, and I'll just zoom into it so you can see it a bit more clearly. As you can see that we've got 47% dissatisfied, 37% satisfied. What is the biggest discriminator between those who are satisfied and those who are dissatisfied? Well, it turns out that that is exact diagnosis. And you can see here it's saying if you're less than equal to dissatisfied, then only 8.1% of people are in the overall satisfied group, satisfied of the overall satisfied group. 81% of people are dissatisfied. So that's interesting. I can actually change the the appearance of the text here. So I just say, look, dissatisfied or less. That might be a bit easier. Higher than dissatisfied through neutral. So that basically means neutral. Um, and higher than neutral through satisfied, and higher than satisfied. So that basically means okay, look, that means if you're in the very satisfied group for exact diagnosis. And it basically says if you're very satisfied with your exact diagnosis, then 93% of people in that group are in the satisfied group for the overall satisfaction. So it's a nice way for us to kind of visualize that. We can see that, we can see that where the data is flowing, what variables impact of that for the people who are dissatisfied with their exact diagnosis. That you can actually split them further with their quality of experience at doctor, and if they had a bad experience at a doctor, then they're even more likely to be dissatisfied. And if they're a bad experience at doctor and they're older than 31, then they're even more likely. You can see there's hardly any other groups here in the satisfied group, even more likely to be dissatisfied. So it kind of tunnels down through the data. So that's how we might use that with satisfaction data. It's quite good for finding drivers of satisfaction and finding what factors are related to it. So even when people who are, fairly satisfied, higher than neutral through satisfied, so in the satisfied group, you can actually find that some of them are less likely to be satisfied if the time of appointment was not convenient to them. And that drops from 70% down to 52%. But if it was convenient to them, then it increases 92%. So it's quite important for businesses and organizations to figure out what they need to get right in order to drive up their satisfaction. Now, having done that, let me just shut this output down because we're going to open up a different data set now. I'm still using decision trees. What we're using is something here called related to patient length of stay. But this actually is a data set. Let's see how many cases in it. Oh, there's quite a lot. There's 4,000 cases in it, 4,300 cases in here. This ships of SPSS. And we've got they relate to heart operations, I believe. So, and we've got a lot of information here about how long they were in hospital for and what the procedure was. So if I look at the procedure here, I can see that, some of these are like a PTCA, some of these are like a heart bypass type procedures, split two different ways. And we've got a lot of different outcomes associated with it. Some people died, some people Some people had to be readmitted and so forth and so forth. So what I did was I just simplified the outcomes down into a result which was well or other. So well was, yep, pretty good recovery, 81% well, 18% something suboptimal that that didn't occur, that perhaps wasn't as good as it should be. And there's a lot of variables in here, so to make it simpler, we can run a little procedure here called using a set. You can define sets of variables, and it helps you mask out the sets that you don't want to work with. So if I just say I want the decision tree set, that's a group of variables that I've defined. Click OK at that point. You can see that the data set gets a little bit smaller at this point. So I'm just working with smaller data set. Let me just see if I'm doing that correctly. Yeah, decision tree. Yeah, so just get rid of some of the variables. And then I can do some basic analysis here. So I'm going to just do a really basic analysis running on a subset of the variables. So I'm going to say, let's look at the key outcome here, which is the surgery result. Was it well or was it other? I'll just pick a few here. I'll pick things like gender, blood pressure, whether or not they're a smoker, cholesterol, and history of angina. And if I just run with that really, really basic decision tree, we'll see what happens. Click OK. And it's producing a very simple decision tree for me here. So if I can zoom into this, I can see that one of the critical outcomes here is, whether or not the blood pressure is normal or low on hypotension versus hypertension with high blood pressure. So we can see that if it's normal or on the low side, 12% fell into the other category, 87% were well. Whereas if they had high blood pressure, that drops to 70%, had a good outcome. And if they had high blood pressure plus they had high cholesterol, then that drops to 63%. And if they had a history of angina, that drops to 60%. So we're seeing which ones have the worst outcomes, which ones have the best outcomes. So those who have no history of angina have good blood pressure, 92% well, and who have normal cholesterol, 95% well. So we can see what factors are driving this. I can actually ask it to tunnel down a bit deeper because you can see the smallest group sizes here are 420, 967. These are quite big. That's actually quite a big sample size for a data set. This will stop at a certain level. I can actually go into criteria here and say, look, I will allow you to go into smaller group sizes. You can see the smallest group size by default it can get is 50. And before the tree splits, there must be at least 100 cases. That's called the parent node. Well, that's not what's stopping it. What's stopping it is that it's got a default depth of 3. If I put in default depth of 4 and click OK at that point, it potentially can get longer. It can potentially get further. I don't know if it has in this case. But then I have got a limited number of fields in there. So let's say I put in a bunch of other things like diabetes, obesity. I can put all these other factors in. I don't generally like doing this. I wouldn't recommend this as an approach because you're kind of like treating everything as like a cement mixer and just chucking in, you just get a really complicated model. But one of the things that does happen when I do this is that I notice that the biggest factor changes it instantly. If I run that, it's taking longer to run. It's a much more complicated tree now, a wider tree. And the biggest factor changes instantly because if we zoom in on it, we can see that the really big thing that affects the outcome is the type of treatment they had, the type of surgery they had. Whether it was a PTCA or was it the CABC, whether it was a bypass. So if I do, let's say we just isolate, let's say, well, we're really just interested in the 1,610 people who had the bypass. Well, if that's the case, then I can just filter everybody else out and go to select cases here and go, look, if the procedure, which is down here, surgical treatment, is equal to 2, then just keep those guys. We can check that and make sure that 2 is CABG. Oh, hang on. Yeah, CABG. Yeah, there's 2. Yeah, click OK. Click continue. OK. And you can just check that, make sure that, you're running the correct one by doing descriptive statistics on procedure. And you can see it's only CABG. It can't see the other procedure at this point. So now if I run my decision tree again, procedure isn't necessary anymore. Shouldn't be chosen really. I'll run that again, let's say. Yeah, so CAB, the procedure is no longer important because they're all belong to one group. And the things which really drive the outcome now is the type of drug that they were using, whether or not it was streptokinase or alteplase or retaplase or none. So clot dissolving drugs. So if they had, streptokinase, then the number of had a suboptimal outcome is 43% on these, and its number a suboptimal outcome was 22%, and there was none used. Suboptimal outcome is 59%. And then we break it down into, well, did they have cholesterol or not? And we're finding subgroup of subgroup of subgroup. So, and we go down into whether or not this digitalis was used or are they physically active. We can see for each group here what factors are driving, the biggest differences in the surgery result. And in fact, you can use this as a predictive model. You can actually ask it to save prediction scores out and say, what's the predicted value? What's the predicted probability? And you can apply that model to a new data set. So you can actually save that model and apply it to a new data set. Here it's giving me probability scores. You can see that it's only basing the probability scores on those that were selected for the analysis. Because this is a risk score of them being in a in the well group or the suboptimal group. And it's basically related entirely to their percentage to whichever node they were in, whether or not they're in the well group or they're not or the other group. So it's which node they're in, the node being which group they end up in this table here. So every terminal group, every terminal node here is given a number. Like here was like you could end up in node 8, you could end up in node 9, you could end up in node 10, and whatever your percentage is for that group, that's your percentage chance of survival. At each point, it's doing a chi-square test to make sure it's including the variables which are quote unquote most significant for that output. So later on, for example, I'll be doing a webinar on marketing, and decision trees are used a lot in marketing for obvious reasons because they're a great way to find out whether or not people are likely to, cancel a subscription or respond to an offer and that. And as a result of that, they have a lot of different uses. But they are predictive models and they are exploratory tools and they're profiling tools, so they're very, very useful in that sense. Before we leave that section, just a little reminder here that there are other things you can also use it to model satisfaction, as we can see, and we can use it to model health outcomes. We can use it to model people's likelihood to be readmitted to hospital, that type of stuff, and relapsing and treatment, and anything where you've got some sort of key critical variable, key critical outcome, which could be impacted by many different other factors. So the next thing we're going to look at is estimating odds ratios and relative risk scores. We've got to speed up here a little bit because running out of time. I want to get on to survival analysis. So I'll do this quickly. Suffice to say that measures of risk play a crucial role in healthcare for several reasons: assessing treatment effects, measuring impact of treatment, of course, interpreting clinical studies, public health decision making. Evaluating vaccination programs like things like the COVID vaccination program. Risk communication. It's often a simpler way to communicate complexity is to give politicians and policymakers evidence in terms of risk. And it's a good way to identify high risk populations. So there are two key measures of risk in SPSS. One is called an odds ratio, and the other is called the relative risk ratio. These methods are both measures of association. Rather than just looking at whether a relationship is statistically significant, we wish to measure how strongly they are related. In healthcare applications, these values can indicate if exposure to a factor can increase risk of an outcome or conversely have a protective effect. We can also use confidence intervals to show if the effect is statistically significant. One type of method is based on calculating odds and the other is based on probabilities. So I need to explain what we mean by that. Let's just touch on odds versus probability. When you want to find out what the odds are of getting a six when you cast a die, when you roll a die, it's 1/6. That's the probability. If you want to find out what the probability is, it's 1/6. So that means that basically it's 1/6, which is in 16% of occasions you will roll a six. But the odds are different. Odds are calculated differently. Odds are slightly different. Odds are simply saying for every six rolls, five of them will be a number other than six. So it looks at the number of outcomes which aren't six and the number of outcomes which are six. Whereas probability looks at the number of outcomes which are six versus all possible outcomes, including the six. So they're slightly different. So odds are calculated differently from probability, and we just need to be aware of that. Okay. Now, with an odds ratio, what we're doing is we're calculating the ratio of the odds of A in the presence of B and the odds of A in the absence of B. And it's regarded as more difficult to interpret than relative risk because, of course, most people don't think in terms of odds. Most people tend to think in terms of percentages, which is more akin to probability. So relative risk ratios are the ratio of the probabilities, i.e., the probability of an outcome in an exposed group to the probability of an outcome in an unexposed group. Okay. So in this example, we're going to look at the associated risk between smoking and angina. And here the risk factor, we need to be aware of what the risk factor is. The risk factor is whether or not you're a smoker. And the outcome is, of course, angina. And we can use SPSS crosstabs, as we've seen them earlier on, to compute both the relative risk factor and the odds ratio. It does both of them for you by default. So this is what the crosstab we're going to create is. It looks like I'm just going to run that. So I'm just going to click back to SPSS here and open the data set, which is odds ratio and risk. And I'll just go and create this little crosstab here. I'll go to analyze, down to descriptive statistics, down to crosstabs, and I'll put smoker 2 in the rows and history of angina into the columns. And then I'll ask in cells, I'll ask for row percentages and click OK at that point. And that's basically our table here. This is just the same thing that we're seeing in the slides here. 68.2% of the smokers have a history of angina. So that's the row percentage. 44% of the non-smokers have a history of angina. So this is the 2 by 2 table, what we call 2 by 2. And the chi-square value, if you did a test of that, I would say, yeah, that's definitely statistically significant. It's less than p equals less than 0.001. So be rejecting the null hypothesis that angina and smoking were completely unrelated to each other. Okay. Now, the key here is that we want to get it, and this is kind of awkward, and people wouldn't necessarily know this, from SPSS. Hence, part of the reasons why we actually did a video on it, which we got on our website, and one of the reasons why we included it in this webinar is because people wouldn't necessarily know this. Is that if you want to calculate the odds ratio and relative risk ratios correctly, you need to know which variable is the outcome, which variable is the risk factor, and the risk factor goes into the rows. Normally in crosstabs, it doesn't matter which way around variables go, but here it does. The risk factor goes into the goes into the rows, and the outcome goes into the columns. And more importantly, it's really paying attention to the first category in each of these groups. So hence I've recoded the variables. That's why I got smoker 2 and angina 2, because I made sure that yes was coded as 1 in both groups so that that was the first category that was shown. Note the row and column positions of the risk and outcome categories. This affects the calculation. So how does it do the calculation? Well, what it does is just looking at the counts. So to begin with, if we're looking at the odds ratio, it just looks at the yes, how many yeses and how many no's did you get in the yes group for smokers, and the yes group for angina and the no group for angina. And basically it says, okay, well look, I'm just going to take one as a ratio of the other. I'm going to do the same for the no group here. Take one of the ratios the other. And then I take the ratio of the ratios. So basically, what's the ratio of the yes group for smokers against angina? Yes, no. And what's the ratio of no group for smokers against angina? Yes, no. And that basically gives us a value of 2.69. What does that mean? It just means the odds of having angina are 2.6 times greater for smokers than for non-smokers. And as long as you say the odds, then you're fine. Okay. Um, this is a measure of association. It's not a causal statement. For the other one, for the other measure, relative risk ratio, what we're doing is we're not looking at the yes and no. We're looking at the yes over the total. This is why, because that's how probability is calculated. We do the same thing as beforehand. We look at the ratio of one of the number of yeses against the overall total, and the number of yeses in the no group against the overall total. And we take the ratio of those two things, and basically it says now the probability of having angina is 1.54 times greater for smokers than for non-smokers. Okay, whatever that baseline probability is. Baseline probability, you might have a 20% chance anyway, but it says 1.54 times greater. So if I want to get that result in SPSS, what I'd do is I go to crosstabs here and I'd go to statistics. And all I do is just check this box marked risk. That's it. Click continue risk. And it will give me these values here. Here's the odds ratio value here, 2.69. And here's the risk of having angina. That's a relative risk ratio, 1.538. And that's as simple as that. But of course, unless you knew which way to put the variables, unless you knew which way to code the groups, you might get completely the wrong results. So hence we're going to the trouble of kind of illustrating it. Bear in mind that we do get these two values out again exactly as we calculated earlier. So there's the odds ratio, there's the relative risk ratio, and also bear in mind that although the odds ratio and relative risk ratios are quite different here, generally speaking, these two numbers start to become much more similar to each other when the proportion of people with the condition turns out occurs relatively rarely. So when you're dealing with quite a rare condition, below 10%, something like that, you find that these groups, the odds ratio and the relative risk ratios are similar to each other. Now, in terms of which one you quote, that depends on usually on the research that you're doing and what other papers and what other previous research you're comparing your results to. So if the standard is that they use odds ratio, then you use odds ratio, and if the standard is that they use relative risk, you use that. What about these values? These are confidence intervals. And it simply says 95% confidence intervals provide an indication as to how much these values are likely to vary from one sample to the next. For both the odds ratio and the relative risk estimate, both of the intervals are positive, so it's likely that this increased effect exists in the population. It could be as low as 2.4 in terms of the odds ratio, or as high as 2.9, or in terms of the relative risk ratio, it could be as low as 1.48 or as high as 1.59. It's telling you the range that exists in, but either way, it is definitely an increased effect in the population. That takes us to our last example. Our last example is survival analysis here. And we're looking at survival analysis, and we're looking at pain medication in this example here, and the effect of when pain medication takes an effect using a survival analysis approach. I'm just going to again close down the output here because I don't need that. And I'll close down the syntax because I don't need that as well. And let's just jump into survival analysis so you can see what results, what outcome, what output you're going to see, and how to interpret it. So, survival analysis refers to a family of statistical procedures where the outcome variable of interest is time until an event occurs. It is commonly employed where researchers are interested in modeling the effects of different treatments or conditions upon patient survival time. For this reason, survival analysis is a key technique used to analyze the efficacy of pharmaceuticals in studies of disease progression or prognosis. So it's sometimes called time to event data, and that's because there's a time element to it. These data are always comprised of two key variables. One is an outcome status, indicating if the event has occurred or not, usually whether or not they've literally survived, whether or not they're alive or dead, or whether or not they've relapsed or been readmitted, or could in this case be whether or not a drug has taken effect. And the second variable is saying how much time has elapsed before the event occurred or did not occur. It's actually used a lot in insurance, because it's kind of, you're often dealing with kind of inevitable events. There is this concept of censored data. I just need to touch on this. It's a very important concept within survival analysis. So censored data is unavoidable. And it basically means missing data. It refers to unknown circumstances where we, for an example, don't know how long the patient survived or how much time elapsed before the event occurred. It's an added complication of the analysis, but it's one that's incorporated into the various calculations that estimate survival time. Let's look at how censored data can occur. Well, one is that the data isn't censored, that you started the study, you included a patient, you had all the information that you needed about that patient. You knew when their disease started, and you knew when the event occurred. So maybe it's death or something like that. And you have the complete information. So that's non-censored data. But other times you just don't know what happened to the patient because they dropped out of the study. And that happens all the time, where you just don't know if the event occurred or not. You don't hear back from them. Or the event did occur, but because you can't keep studying people infinitely, you got to say, I'm going to look at the last 5 years of data for these patients. You know, it might be that some of them, joined the study relatively late and the event did occur, but it occurred outside of the study time frame. That's called right censoring. Or you don't know when the disease or the condition started. So that's called left censoring. So that's also, I mean, how can you estimate the time correctly if you don't know when it started? Or sometimes you don't know when the event itself happened. This is particularly true if if the study's based on like 6 month checkups or something like that, or annual checkups. You don't really know when the key event, like the establishment of a condition or disease occurred. So it's just to be aware that there are different ways in which data can get censored, but it all refers to the same thing, which is that you don't know if the event occurred or not. So there are three different output types from survival analysis. I'm just breaking it into three groups here to make it easier for you. One is what we call survival tables. These are cumulative survival tables. They're just tables that show you what proportion of patients experienced this event at a certain point in time. The second one is group comparison tables or tests. These are usually statistical tests to find out if one treatment works versus another treatment. And the third one is survival plots. Survival plots are just what you would get if you used the tables and put them into Excel and decided to turn them into line charts. And so the survival plots are just illustrations or just visual representations of the cumulative survival tables. So we're going to run something called Kaplan-Meier survival analysis, kind of classic survival analysis. And we've got a sample data set containing 200 rows of data, and each row represents a patient receiving anti-inflammatory medication for treating chronic arthritic pain. The time to event variable is the time the medication takes to have an effect, if it does at all. We have no idea what units the time to event variable are measured in. Could be minutes, it could be hours, it could be days, it could be months. We don't know. It is, after all, it's chronic. It's a chronic or arthritic pain, so it could be months. The event variable denotes whether or not the event occurred or the patient or the data were censored. And a key additional variable measures whether or not the treatment was administered with a new drug or a standard medication. You can get this data set yourself. It's called pain medication. It's included in the sample files folder where SPSS statistics is installed. And this is what I'm going to do. I'm going to set it up like this. I'm just going to copy this. I'm just going to go. There's my time data. There's my status, whether or not it's taken effect or not. And I'm just going to go down here to survival and down to Kaplan-Meier. And I say, what's the time variable? This is the time variable. What's the effect? Well, the effect is their status, whether or not it took an effect. So one is censored. We don't know if it took an effect. One is one. It definitely took an effect. So I say the event is one. And then I've got this treatment option here, which is the factor. We've got two different types of treatment. We've got drug A and drug B, the new drug and the existing drug. We want to see if they make a difference. And because I want to do some statistical tests to find out if they make a difference, I'm going to ask for some statistical tests, and I'm going to go to options here and ask for some charts. And that's it. And it's all set up at this point. So I've set this up. I've asked for these options. You can do this yourself. And what we're going to get is this survival table out the back. So I'm just going to run the procedure now and then just walk through the output quickly. There's my table, there's my survival table. That's for the new drug, then the existing drug. These are showing me what proportion of patients had the drug had taken effect on. And it gives me statistical tests and it gives me some charts out the back. So let's have a quick look at these. So first thing is First thing we see is whether or not what type of treatment it is. So the first top of the survival table refers to the new drug or the existing drug. It happens to be the new drug. And this is the time to effect zero point 0.6, whatever that is, zero point 0.6 months, zero point 0.6 hours, zero point 0.6 weeks or something like that, I don't know. But at zero point 0.6 weeks, we find that two events had occurred and we can see it taking effect. So that says the status is taking effect. So no, non-sensitive cases are not included, just saying it's taking effect. And then we have the cumulative survival, the portion of non-sensitive cases where the effect has not occurred yet. So how many are left? So 98% of the patients hasn't had an effect yet on. There was standard error, which is just an estimate of how reliable it is. That gets bigger as you go down through the table because you can because you got smaller sample size because you're taking more and more patients out. It's taking an effect. Cumulative events. So at zero point 0.9 time units, it had occurred 5 times. It had an effect on 5 patients. There were 99 patients remaining. So it's just really counting. It's just counting through as if we were just discharging them out the door and saying, how many are left? How many are left? How many has it? How long has it taken before that patient has an effect? And then we have other output, which is just basically telling us what the average is, what the mean time it takes an effect. Well, for the new drug, it takes an effect at 4.8 time units, 4.8 weeks, let's say. Existing drug, it takes a bit longer, 5.1 weeks, and that gives you, confidence intervals. It tells you the same for the median values, 3.7 for the new drug, 4.1 for the existing drug. Gives you percentiles, bottom 25%, middle 25%, top 25%. And then very importantly, it gives you statistical tests here. And all of these statistical tests are showing a non-significant result. They're all above 0.05. And in log rank, it means all the time points are equally weighted in this test. So it's not strong, it's not a really good test because it means that even the later time points have the same weighting as the earlier time points, and the later time points don't have as many cases. And Breslow time points are weighted by the number of cases at risk each time. Less power when percentage of cases is large. Early events are weighted more heavily than later events. And Taroni ware is basically it's a compromise between the two. Now, in this case, it makes no difference, which method you're using, because in either case, it's saying that there isn't really a difference in the efficacy of the two drugs. We can see when we look at the cumulative survival function, this is the time to effect. This is the number of cases that are remaining. So time to effect. So let's say at 6 time units in there for the existing drug, about 40% are remaining, whereas for the new drug, it's about, what's that, 36, 37%, something like that. So you can see what proportion are. And of course, if this gap was much bigger between these two groups, we might well find that there was a statistically significant difference. The cumulative survival is just the same chart, but in the opposite direction. So it's usually saying how many people are surviving at this point. So how many events are occurring. So it's adding up. And the last one here is just to point out that the survival function denotes the probability that a subject will survive beyond a given time point. The hazard function denotes the rate of failure of non-survival occurring at a given time point based on the fact that the subjects have made it this far without encountering an event of interest. The cumulative hazard function, however, points to the expected rate of occurrence in a given time point. I'm only putting this in here because people get confused about it so often. So the values can exceed 1. If the periodicity was measured in years, for example, one could reach a time point where a given event might be expected to occur 1.5 times on average by that stage. So if you're talking about something like a stroke, we all know a stroke could occur multiple times. It doesn't occur just once. So you will get a cumulative hazard function where instead of having a proportion along the side, it's telling you how many times you would expect to see it within that time frame. Okay, we've got to the end here. But just before we go, you should be aware that we have a lot of other useful video resources. If you get your slide deck out and you download your slide deck, you'll be able to click on these hyperlinks and it will take you to these other video resources, which will go into this in a little bit more detail. We also have our own chatbot now. We've got something called Chat SPSS. It's just a free generative AI chatbot developed by Smart Vision Europe based on official IBM documentation of procedures. So if you go to this chatspss.com, You can sign up for that and you can be able to interrogate it and ask it questions. It's based on all the IBM documentation of SPSS procedures. It's completely free and you're allowed to use it yourself. We have decades of experience, of course, providing guidance, training, consultancy in the delivery of data science initiatives. So you can buy your analytical software directly from us, often with discounts, and we can assist with the pilot and implementation of that. You can buy SPSS software directly online from us. We offer formal classroom training as well as virtual training and online self-training courses, which are freely available to our customers. We generally offer no strings attached technical and business advice related to all things analytical. And we provide tracked technical support services around the IBM SPSS product line. I do hope you find that useful. We look forward to you logging in again. In the next webinar, we're going to be looking at using regression techniques in healthcare applications. Thanks very much, and we look forward to tuning in again. Thanks.